All right. So everybody that's here so far, I'm just going to call people out. We don't have to do I'm here. I think we've established everybody that's on is here. So we have Autumn, Ben, Caitlin, Daniel, Jeffrey, Kristen, Mitch, Steven.
John's here too.
Okay. I didn't know if he was in.
You keep going in and out.
He keeps going in and out, or I do.
It might just be me.
It could be this thing we've been fighting with computer difficulty all day.
It's not just you. I heard it too.
Yeah, I heard it too.
Okay. Well,
I heard it too.
if I have to, I'll get on my cell phone and we'll make it work. Did I miss anybody? Okay. Well, let's go ahead and get started. We'll start with chapter 14. All this is a medical overview. A lot of this should be refresher from the assessments we've done. So obviously people who need EMS have some problem, whether it's a medical problem, a trauma problem. Sometimes they get lucky and they get both of them. Trauma emergencies obviously are stuff that happens to the body. Okay. Some kind of physical object has caused damage to the body. Medical emergencies are classified as illnesses or any kind of disease process. Respiratory, with that, deals with your lungs, problems breathing. If you don't have enough oxygen, that's a respiratory emergency. If you're not breathing at all, that's another problem. Cardiovascular deals with your circulatory system. Neurologic, just based on neuro, if you look at it from way back when we did all our terms, neuro means brain. So a neurologic emergency would mean something with the brain, whether that's a traumatic head injury or some kind of infection. GI problems could be anything related to the stomach. You have your appendicitis, diverticulitis, pancreatitis, cancers, cirrhosis, you name it. Endocrine, most of the time that's going to be diabetes. Hematological emergencies, going to deal with your blood. So sickle cell, any kind of blood clotting disorders. If you lack factor V, that would be a hematological emergency. And then immunologic emergency is just where your body does not do well with any kind of virus or infection. Oh, I can't talk tonight. Toxicologic emergencies or poisonings, substance abuse, your opiates, heroin, stuff like that. Gynecological emergencies obviously deal with female reproductive organs, so males do not have to worry about that part. Then you have your behavioral, your psychiatric issues. Those types of folks may not always have the problems presented the same way. So just be aware whenever you go on some type of problem where you don't know what's going on or they don't know, it could be something behavioral. All right, so we've talked about patient assessment before. We've done that. Like it says, most of our assessment is going to focus on whatever the nature of illness was or the mechanism of injury, any symptoms that they're having, and then what their chief complaint is. Chief complaint obviously is not what we think their problem is, but what they're complaining of. So whatever that patient thinks their problem is, that's the chief complaint. It may not be what we end up treating them for, but that's what they called us out for. All right. Medical history. Always good to get a thorough medical history. Obviously, if we don't get anything good information, we could do something detrimental to the patient. They could be allergic to something we're fixing to give them, and we wouldn't know it unless we ask. Don't assume that just because they're presenting with chest pain that they're having a heart attack. It could be something else. Don't kind of get tunnel vision when you're trying to assess these folks. At the same time, if they have injuries, they may have something else going on as well that caused that injury. Obviously, if somebody gets their arm cut off, that's going to be a pretty big deal to them, right? We talked about distracting injuries. Make sure they don't distract you from getting the rest of the information you need. Obviously, if they're uncooperative or hostile, you're probably not going to get enough information anyway. Try to be calm. Try to be professional. Non-judgmental. That's sometimes really hard to do depending on how these people are acting. Don't call them out. Don't put a type to them. Don't do anything that might cause more problems with this patient. At the same time, if you go on this residence 14 times a month, oh, great, it's Jerry calling again. It may be the one time he actually has a heart attack. And if we're being butts about it and we don't care, we don't do a proper assessment, he could die. And if he dies, it would be our fault because we didn't do a proper assessment. We didn't find out what the real problem was. All right. Scene size up. We talked about that before. That's kind of your windshield survey. Make sure the scene's safe. Make sure you're not going to go into something and get hurt. Make sure you take your standard precautions. At this point now, that's making sure you've got, hopefully an N95 on. If not, just a mask, gloves, whatever you can. Make sure you know how many patients you're actually going to have. So your index of suspicion for your illness is how aware you are of these serious problems this person can have. Okay, if they're complaining of, oh, well, I'm having trouble breathing today. Okay, well, that could be they're having an asthma attack, or they have COPD, or this. Prepare yourself for which problems it could be. That's where that kind of index of suspicion comes from. Make sure you do a good impression. Remember, that's when we walk up and we see the patient the first time. What does my patient look like? Okay, that's looking real quick, seeing if there's any obvious life threats, seeing if there's anything we need to take care of immediately, seeing if they're alert. So if you walk up and they're laying on the ground and they're moaning and groaning, but they don't respond to you, okay, your primary general impression is going to be that they're altered. After that, it's the ABCs, stuff we've gone over plenty of times before. Make sure their airway's open. Check rate, quality depth, make sure they're breathing well enough. If not, put oxygen on them. If they're not breathing, bag them. Use an OPA, NPA, whatever we have, and make sure that they're getting enough oxygen, whichever way we have to do it. All right. Circulation, obviously, if we can check a radial pulse, great. If they have one, they've got a fairly decent blood pressure for the most part. Same time, when you're checking that pulse, check their skin color, check their temperature, check their condition. If it's tinting a little bit, that's probably dehydration. If they've got cuts and scrapes, make a mental note of that. If your patient's unconscious, don't go straight for the radial. Go ahead and check the carotid artery. That way, if they don't have it, you can start compressions. So deciding when these folks need to be transported. If they're unconscious or altered, they obviously need to go quicker. Okay, they need to be emergent patients. If they have some kind of breathing problem, or if they have severe bleeding, shock, anything that can be an obvious big problem, they probably need to be transported quickly. It's always better to err on the side of caution. All right, talking about history taking, again, get a good history. If you can't, if they're unresponsive, if they're at home, check around, look for medication bottles, look for a tag. Look for a bracelet. Maybe they have information on it. Ask the neighbors if they're available. And do what you can, but don't waste an extreme amount of time trying to find it. All right, so sample history again. We know what sample is, right? Everybody knows what sample. Y'all can just tell me yes or no. That's fine.
Yeah.
Okay.
Yes.
OPQRST. Just make sure you guys know those, especially when you get on stressful scenes. Those are really good to fall back on, especially if you can't get your thoughts straight. Even if you only get, SAM out of the sample, whatever information you can get is always helpful. And then the tacos mnemonic. May actually have to take a look at that one. Let's take a look real quick at that one.
Fun fact, it's Taco Tuesday.
Oh, I can't use my brain right today. All right, so it's tobacco, alcohol, caffeine, over-the-counter meds, and sexual or street drugs. So we learned something new together today. I did not know that. I did not know that, but that's okay. That's a good one to remember, especially if you have somebody who's altered. All right, secondary assessments, we know about that one. It's obviously after the first. Most time, that's in the ambulance. Okay, that's whenever you've gotten everything taken care of, you have some extra time, you recheck everything. Sometimes you may not be able to get to, depending on what's going on with the patient. If they're unconscious, it's a good idea to check everything. Even if we get in there, we've assessed them, we've seen some problems, we're taking care of it, we need to look at the entire body just to make sure we don't miss anything. Because this patient can't talk to us, they can't tell us what's going on with them. Again, that just goes over kind of what we've already done. Head to toe, double check everything, look for your DCAP, BTLS. Vital signs, I think we know how to take vital signs, get you good initial blood pressure. You can't, it says consider obtaining blood glucose. You probably need to do it anyway, especially if you have an unconscious patient or an altered patient. It's no fun sitting there fighting with an altered patient, getting to the hospital and realizing that their blood sugar was 35 and you could have done something for it. So if they're unconscious, altered, otherwise abnormal, check a blood glucose. It's very easy, very quick. Right, reassessment again. Every time you do something, if you stop a bleed, reassess. If you put in an eye gel and start breathing for them, reassess. If they start breathing on their own, reassess. Always consider the need for ALS backup, especially if things are getting worse or you can't stop something. And then make sure you document anything that changes, whether that's good or bad. If you stopped the bleeding, the blood pressure went up, document it. If you stopped it and it went down, or you couldn't stop it, document it as well. All right. So again, a lot of these emergencies, most of them do end up beyond the scope of an EMT. Okay, a lot of them require medications. So just be aware of that if you have to ask for ALS help. The good thing out here, pretty much most of the time, whenever anybody runs out together, we've got enough help. We've got enough qualified individuals to give medications. Scene times with your medical patients is probably going to be longer. You have to ask more questions. It's not going to be obvious. Okay, that person may have chest pain, but why? We don't know. If they're a trauma patient, if they have chest pain, it's probably because they were shot or stabbed or hit. We can see what's going on with that patient. And kind of a no-brainer down there, critical patients, they always need that transport, rapid transport. If it looks bad, it needs to go fast. There's different types of transport. obviously lights and sirens, and then no lights and sirens. We have ground units, we have air units. I think we've all seen that. We've all used that. Most time, air transport has a little bit more qualified, I guess is an okay word for it. They're trained a little bit more. They are able to do some more procedures than a ground crew would. So consider that if there's more problems than you can think of. Realistically, when you're choosing your destination, the good thing out here is our main hospitals are right next to each other. But you always want to try the closest hospital as long as it's appropriate. Now, if you're way out over by UT North, you have a patient that's arm is severed or hanging by a thread, they're obviously not going to go to UT North even if it's the closest. You're going to take it to the one that's most appropriate. Infectious diseases. It's rather appropriate for this time we're living in. You're going to approach them just like a normal medical patient within reason. Do your assessments. With these folks, we're asking, have you traveled? Have you been in contact with people who have had this problem, this medication? Just make sure you're being extra cautious and taking good precautions for you. If you find any life threats, if they're having extreme trouble breathing, if their blood pressure's really low, manage what you find. At the same time, these people are probably freaking out too. Be empathetic. Feel for them, okay? We don't need to be stone cold, not caring individuals, okay? That puts them on edge, makes it worse. Try and keep them warm. And again, use standard precautions. Here we go. Epidemics. Epidemics, when it exceeds what we originally expected, and then the pandemic, like we're currently dealing with, is when it's on a global scale, when it's everywhere. So before, this year, the biggest pandemic we had was the flu back in 2008, 2009. A lot of times the flu is worse for those who have other medical problems. Older folks and real young folks have more complications as well. As it says, it's transmitted just from sneezing, coughing, pretty much the same way COVID-19 is. So there's a couple little tidbits that we should know and take caution with. Wear your PPE, gloves, eye protection. If you've got a respirator, great. If not, an N95, surgical mask, whatever you can get. Ideally, place these masks on the patient as well. A surgical mask may not be much benefit from our standpoint, but it keeps that patient, if they have it, from spraying those droplets, aerosolizing that virus all over the place. Does that make sense?
Yes.
Okay. All right. So here's another virus. All right. Herpes simplex. It's very common. Has a fairly obvious presentation to it. Depending on the patient, it can cause worse problems. Eventually it could cause pneumonia, it could cause meningitis. You just have to be real careful with it. The good thing is, it is just, sorry, I'm moving something. It's through close personal contact. So if you stay away from everybody, you'll be just fine. There we go. HIV, unfortunately, it's something we do have to deal with. There is treatment for AIDS. Not a cure per se yet, but it can give you a decent lifespan if you end up having it. The good thing is the risk of exposure is very low. Again, it's blood and body fluids. Most of the time, if we're taking our standard precautions, we don't have to worry about that. Most of the time, when we get close to getting an infection from this, it's more IV sticks, dirty needle sticks, things like that. Downside is most of these folks may not have symptoms. They may also not say anything to you. But in the case if you do get exposed to it, always report it. Okay? Don't ever sit there and say, oh crap, I don't know if I got exposed or not. Go ahead and report it, get tested, get looked at. Better safe than sorry. All right, hepatitis. Liver problem, your liver becomes inflamed. Good thing is toxin-induced hepatitis is not contagious, okay? Hepatitis B, however, is. That's why we get vaccinated for it. Same thing with C. Downside is we can't tell which patients are contagious or not. They can tell you, oh, well, I have this type. Okay, well, are they 100% sure? We're not. So again, like a broken record, standard precautions. Meningitis, again, that itis, it's inflammation. It's on the covering of the brain and spinal cord. Good thing is, again, these are not contagious for the most part. Take standard precautions, you'll be safe. We can treat these with antibiotics. Depending on which one you're treating, whether it's bacterial or viral, you need to let your employer know or your medical officer, whoever's in charge. That way, if they need to get you some medication, they can, or they can monitor you. TB. Everybody likes TB. Okay, TB presents most time night sweats. Oh man, my brain just fried. Sometimes they may not know that they are infected. Okay, they could have a dormant TB but still be a carrier. But the ones who have that cough, who can spread it through the air, those are the ones we need to be worried about. These are the ones that we originally were wearing N95 masks for, or should have been wearing. Downside is we don't have any 100% protection from it. Okay? That's why we get a TB test every year. Whooping cough. All right. It's where those kids will cough and it kind of has a little whoop sound at the end of it. It's also called pertussis. Good thing is we got vaccinations for it. So vaccinate your kids. Pretty sure most of us were vaccinated for this already. At the same time, put a mask on them. Same thing we've been hammering home. Oh, MRSA. Has anybody dealt with MRSA before?
Nope.
We have.
Yes.
Yes.
Yeah.
It's not very fun. Okay. Main thing is it's resistant. It's contagious, very contagious. Just be careful. Wash your hands. Standard precautions. Wear gloves. Always ask, especially if you're going to nursing homes or you're going to the hospital to take care of a patient. Ask, hey, do they have anything? Do they possibly have MRSA? You know, what are we going into? That way you're prepared ahead of time. A couple different things that increase your risk for it. If you look, a couple of those are pretty indicative for nursing home patients. That's why they usually get it quite a bit. So global health issues we're getting into a little bit. MERS, COV, Middle East Respiratory Syndrome, coronavirus. Not really dealing with that right now, but we are dealing with COVID-19. Ebola that came out in 2014. We had some cases that came to America. Definitely not a pretty virus. Most time what kills you is dehydration. These people would have vomiting, diarrhea for days. If this ever comes back around, just be aware that these people we need to take extreme precautions with. So the way we're handling COVID-19, imagine it times 2. Okay. Because these people, Ebola is a viral hemorrhagic fever. So a lot of times in the end stages, they're going to be bleeding from their nose, from their mouth, their eyes. And that's when they're extremely contagious. If you look right there, it says the fatality rate can be as high as 70%. It's very, very lethal. Definitely do not want it. Same time, if you are these patients present with these symptoms, you may want to ask them, hey, have you traveled anywhere? Have you been in these certain places? That way, if they say yes, you have an indication of, okay, well, maybe they have this infection. And there's a couple questions you can ask. It's really stuff we should be asking anyway, especially with what's going on right now. So again, assessment. Assessment for any patient can be difficult, especially a medical patient, just because there's more going on. We have to dig a little bit deeper. It's not obvious like a gunshot wound. At the same time, these people may have more than one problem. They could be having a heart attack, but they could also be having an exacerbation of their COPD condition at the same time. Or they're a diabetic, but they're also having a stroke. All kinds of stuff can happen all at once. All right. So a seizure is what kind of emergency?
C.
C.
D.
C.
Man, I miss being in class where I could just stare at y'all until y'all answer the question. But so let's see. Seizures.
He ballsy because you almost.
So a seizure basically is the brain kind of short circuiting there for a little bit. Okay, so if it's a brain issue, it's a neurologic emergency. All right, so if an injury distracts an EMT from assessing a more serious problem, the EMT has suffered from what?
A.
A.
Tunnel vision.
A.
I was gonna say, if y'all don't all answer, just find where y'all are and beat you to death. Yeah, it's A. If something distracts you from it, obviously you're getting tunnel vision on that one specific problem. Again, I go back to the amputation because that's a serious injury, but it may not be the only one. It's certainly going to be the one they're freaking out about the most. If a frequent fire calls you because of a suspected head injury, you should never what?
Get complacent.
C.
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 All right.
B. Oh, C.
C.
Oh, I'm gonna. It's you should never assume that we know what the problem is. Okay, just because we've been on this guy 14, 15, 16 times in a month doesn't mean that this time isn't serious. Okay, we've all had those patients where we go on them plenty of times. Occasionally, they end up right and they have a problem. But always be professional, always take it serious. All right, so if your patient is not in critical condition, how long should you spend on scene?
D.
I say A.
D.
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 Yeah,
D. Oh wait. Okay, too late.
that's D. We don't want to stay on scene forever, but we want to stay on scene as long as we can to get the information, the necessary information we need. That doesn't mean sit there and hunt through their entire house looking for a certain medication. Get what we need, as much information as we can within a timely fashion. That could be 10 minutes for that call. That could be 20 minutes. Obviously, if you're sitting on scene for an hour, that's probably not needed. All right. Patient's having respiratory difficulty and is not responding to your treatment. What's the best method to transport?
B.
B.
B as
B.
well.
Yeah. At that point, if they're not responding to this stuff, it's going to get worse. So we need to get them to the closest hospital as fast as we can, so we can get some additional help. All right. Assessing a patient with infectious disease, what should you perform first?
A.
D.
A.
A.
A little bit of a misleading
I'm
question.
doing serious lag problems right now.
Okay. Yeah, I didn't read the whole thing.
A.
It's a, we're supposed to be doing the scene size up. Take those standard precautions. Kind of a misleading question because it's saying when you're assessing the patient, it usually means you're already there, but it's the first action you should. That's when we're going up to the patient. You should be gowned up, gloved up, already checked the area for any hazards, anything that's a danger.
Isn't that kind of normal with most scenes anyway?
It is, but because this is a class, because it will be on a test eventually, and maybe on National Registry, you need to make sure you always start with that scene size up. All right. Patient believes he has hepatitis, exhibiting signs of cirrhosis of the liver. He has what type? Wouldn't gone over it in
B.
the presentation, would it?
C.
Hepatitis B.
I'm gonna go with C.
Okay.
C.
B.
C. So hepatitis C is associated with cirrhosis of the liver more often than not. So anytime somebody has a history of cirrhosis or tells you that they have that, go ahead and assume that they're going to have hepatitis C. You got a 50-50 shot of being right. All right, you got a patient with a fever, headache, stiffness of the neck, red blotches on his skin. So that stiffness of the neck is important.
And D.
D. Meningitis. I think.
D.
Yeah. So it's going to be meningitis. That stiffness in the neck, if you have them kind of put their head down and push down, usually it's going to hurt like hell. They'll also start developing that rash on their skin. Just be aware that these patients, depending on which it is, you need to get looked at, or at least let them know once you transport them. So what are you supposed to do if you're exposed to a patient who has TB?
B.
B.
D.
Oh.
B.
Yeah, you're gonna go get a TB test, see if you have it or not. You may undergo therapy. I don't know. It depends on, I guess, how traumatic the experience was. But you're always going to get a TB test. All right. All the following are factors for developing MRSA, except what?
D.
D.
Yeah, we don't need no wild.
D.
A.
Yeah, it had nothing to do with wild birds. And that's actually the avian flu. So definitely not MRSA. All those were factors. Like we said, a lot of those are also very common with nursing home patients or chronically ill patients. All right, look at that. We survived the first one. All right, y'all take a 5-minute break. And all right, so we've got our respiratory emergencies. Again, all these are going to deal with your respiratory system, your lungs, the upper airway, lower airway, the nares, the pharynx, larynx, all those different body parts. All right. So, what's the number one complaint most people have when they're having a respiratory issue? They can't breathe. I'm tired. I can't breathe. I'm short of breath. Can't catch my breath. So, with that, all kinds of things can cause these kind of problems. Okay, like I said before, it could be COPD, it could be CHF causing it, it could be asthma, it could be an allergic reaction, you name it. Sometimes it's harder to tell. Okay, a lot of times we're going to manage the symptoms and hopefully get them corrected that way. So again, kind of a little bit of the anatomy of the respiratory system. I learned that way back. You got your diaphragm, it's a muscle down at the bottom. Helps you breathe, your chest wall muscles, your accessory muscles. That's kind of like when we're belly breathing, when we have those intercostal retractions, when we're trying to breathe real hard. That's what those muscles are. And then obviously the nerves that go to the muscles that tell it to move. So there's your upper airway. You've got your nose, mouth, jaw. Sorry, I can only see part of it. You got your oral cavity, and then again your pharynx and your larynx down there. That's just the upper airway. So most time if somebody has a problem with the upper airway, you're going to hear that high-pitched sound. Okay, that's when you get swelling in the airway. That's where that comes from. We'll go over a couple different upper airway emergencies later on in the chapter. So the obvious function of the lungs, respiration. Okay, breathing. We're exchanging oxygen and carbon dioxide to keep our body and organs perfused. So we pull in air in with our trachea into our lungs, then it goes down into the bronchi, the bronchioles, and the alveoli, and then that's where the gas exchange really occurs. So that little picture, your inspiration and expiration, okay? Oxygen goes into the blood, your carbon dioxide is removed. So just remember the oxygen-rich blood is coming in from the lungs to the heart to be pumped to the rest of the body, and the carbon dioxide filled is moving into the lungs from the heart. So again, right there, the alveoli, that's where the oxygen goes in through the capillaries and trades out with the carbon dioxide. So your brainstem is kind of what controls those carbon dioxide levels, okay? Regulates your breathing in depth. We'll go over that a little bit later on. But has anybody heard of the hypoxic drive?
Yes, I've heard of it.
Okay.
Yes.
Yeah, we're gonna
Yes.
go into it a little bit more later on, but the hypoxic drive is a change from that carbon dioxide. Because our all of us right now, we're running off the carbon dioxide levels. Okay, we either have too much or too little, and our body changes the way we breathe. Folks that have COPD, breathing issues for a long, long time, their body gets used to that carbon dioxide and then bases it off of oxygen. That's where it changes into that hypoxic drive. Just be aware of that. If you're giving oxygen to somebody, they may start slowing their breathing down because of that. So the actual exchange of oxygen can be hindered. Just, they may have some kind of weird anatomy. They may have a growth or a tumor, a shortened airway, narrow. Diseases can cause that as well. Traumatic injuries, they can have a esophageal tear, a tracheal tear as well, or they might have some kind of problem with the vessels in the pulmonary system or the actual lungs, or they may not transfer that oxygen as well. Most important thing is recognizing those signs and symptoms of inadequate breathing. Okay, they're turning blue, their respirations are increasing, their O2 sat's going down, their nail beds are turning blue, stuff like that. Again, right there, like we were talking about, some patients do have that chronic CO2 retention. We have to be careful with the oxygen administration to those people. A lot of times, if you put an O2 sat on them or pulse ox, the O2 sat will say, 91%, 90%. Ask them if that's normal. If that's normal, you may not have to give them anything. At the same time, if they're looking like they're fixing to stop breathing, give them oxygen. Again, if something worse comes to worse and they stop breathing, we take care of it. But just be aware of that different drive for those certain patients. So there's a couple different things that you can have dyspnea and hypoxia with. Pulmonary edema, your CHF stuff, backflowing into the lungs. Could be from pneumonia as well. Hay fever, pleural effusions, obvious obstruction of the airway. Most of the time, that's an easy one to correct. Hyperventilation. Okay, they may be having a panic attack. They may end up breathing too fast. They're blowing off all that CO2. Our bodies change with that. They won't know what to do to process it. They could be exposed to something, whether it's a chemical, whether it's something in the environment. Be aware of that. That kind of goes back up to scene safety. Make sure you're not exposed as well. And then obviously drug overdoses can do this as well. Most common one, again, are opioids. Your morphines, your fentanyls, heroin, all that kind of stuff can slow your breathing or stop it completely. So like it says, they can have a couple different problems, whether that gas exchange is obstructed. They could have damaged alveoli. Okay, they could have some disease process that has caused that. Obstructed air passages, whether that's from fluid, whether it's closing up because of asthma, obstructed blood flow to lungs, that could be a pulmonary contusion. We kind of learned some of that in chest injuries. Or excess fluid in your pleural space. Okay, that's where you get that pleurisy. Makes it difficult to breathe. So that little table right there, just a couple of signs and symptoms. Like I said, most of us know what these look like. We've seen people have trouble breathing before. Obviously, if they're sat up in the tripod position, they're leaning over, they look like they're having a hard time breathing. They probably are. All right. So upper and lower airway problems, infections. Okay. Some of these can cause obstruction. They can cause difficulty breathing. Obvious things are mucus secretions. If somebody has a cold, if somebody has a sinus infection, things like that. That soft tissue up there will start to swell. Doesn't allow as much air in, which then causes the problems breathing. All right, croup. Croup is a nasty little inflammation. With this, a lot of times they come with a barking cough. We identify it almost like a seal. If you've heard it, you know exactly what I'm talking about. If you haven't heard it, you eventually will. Most time it's kids that are between 6 months, 3 years old. That doesn't rule out any other kids. That's just the most common ones. Humidified air will really help them out. A lot of times, once you get them outside, it ends up helping a little bit. Epiglottitis. Okay, this is where we got it. That little flap we have down there, as it shows, it swells up real bad. They've already got a narrow airway as it is. Now that thing is swollen, they're not getting as much air down into their lungs. One big sign of this is drooling. Rule number one with these kids, just don't make them mad. Don't agitate them if you can avoid it. Keep them calm, because if they start crying, if they start getting upset, what's going to happen? That stuff's going to swell up tighter. Then they may not have an airway. So if we can, give them some high flow oxygen. If it's blow by, that's all you can do. Great. Again, if we can reduce the swelling, awesome. Okay, this is some of the stuff that we end up giving medications for. RSV. Young kids tend to get this. Excuse me. Again, just you're treating the airway and breathing problems. Whether we know that this is the infection or not, it doesn't change what we do for those symptoms. Okay, like it says down there, those bronchioles get inflamed, they fill with mucus. Okay, that causes impaired oxygen exchange. What are we going to do? We're going to give them supplemental oxygen. Try to make up for that. Pneumonia. Has anybody actually had pneumonia? It's not fun.
Yep.
Not a pleasant thing to have. Just know that bacterial infections, bacterial pneumonia comes on a lot faster than it does viral. Viral is not near as bad. Most time, people that get pneumonia are sick quite often. Okay, they already have a reduced ability to fight off infection. Again, we're treating the symptoms, okay? If they're having trouble breathing, we're fixing that, or we're attempting to fix it. Pertussis, we talked about this a little bit earlier. It's that whooping cough. Again, just watch for dehydration. Watch for, if you need suction for secretions, manage the airway. Most of this stuff, since it is respiratory emergency chapter, we're managing that airway. We're making sure that they're getting good oxygen, making sure they're breathing at a good rate. And if not, we're taking over and taking care of it. Influenza type A, good old flu. Okay. We know the signs and symptoms: fever, cough, sore throat, muscle aches, headache, fatigue, lower credit score, you name it. Okay. Be aware that this infection can lead to pneumonia, to dehydration, to much worse symptoms. TB, we talked about that in the last chapter as well. Just take note of that. It can be inactive for years. Okay, they may be dormant. Something may trigger it, and now they have active TB. Just be prepared. Biggest indicator, weight loss without anything, night sweats. Usually if you hear them say, man, I've been sweating my butt off all night. I've lost like 20 pounds and I haven't even done anything. They probably have TB. Again, make sure you have an N95 mask for this, okay? It's that droplet protection. Same thing as COVID-19. So there's your acute pulmonary edema. That's just where we have fluid buildup. It can happen spontaneously, but most of the time it's congestive heart failure. Usually that affects older folks. It's rare. So are you chewing on something?
Sorry, I didn't know my mic was on. My bad.
Congestive heart failure is usually in older folks. It does happen in younger kids. It just depends on if they have a congenital defect. I think we're currently dealing with somebody who's in their late 30s, early 40s that actually has CHF. So just be aware that this is what can happen. That fluid will block that oxygen transmission. COPD, chronic obstructive pulmonary disease. So this is where your alveoli, your airways have a slow process of dilation. They're not opening up. Number one thing, smoking. Smoking can cause this problem. Can also lead into bronchitis. Most of the time, COPD, smoking goes hand in hand. Okay, so never a bad thing to, again, that index of suspicion. If they're having trouble breathing, you notice a bunch of cigarettes, go ahead and ask them, hey, do you have COPD? Have you been treated for bronchitis lately? Those are things to ask. So emphysema is the most common type. Some people may know what COPD is. Some people may understand it as emphysema. Ask both. Okay, they may not know one or the other, but they may know one of them. Okay, your lungs are losing that elasticity. They're not able to expand anymore, so they're not getting near as much oxygen. Just be prepared again. A lot of times these folks, they're going to be the ones sitting over a tripod, breathing heavy. At times, depending on how bad it is, they may ask you to breathe for them. There's a nice little picture of it. You got your normal lungs, your inflamed lungs, and then the obstructed one. So if they do have that fluid in their lungs, they're obviously going to sound wet. Okay, if you've heard that, it's very distinctive. Sometimes they'll sound like a toilet bowl flushing. Always listen to your patient's lungs, especially if they're complaining of difficulty breathing. That way you can kind of get an indication of, okay, which problem might this be? COPDers won't have that wet sound. They may have a diminished sound. They may not have near as much air movement. At the same time, they could be having multiple things going on. They could have aspirated a little bit. Let me open the chat thing so I can see whatever it is. Well, they probably wouldn't listen. Dispatchers probably wouldn't listen to me anymore anyway. So I haven't been out there in a while. They're not as nice to me anymore. At the same time, if you're not sure if it's wet or if it's dry, that's okay. Okay, you know there's a breathing problem, treat it. Give them oxygen. So there's your asthma, hay fever, anaphylaxis. They've had some type of allergic reaction. Okay, what that does is, like we talked before, it kind of constricts everything. So everything gets tight. just like that picture shows. So that right there shows you that there's a significant reducing of that space we can get air through. That's where we get that high pitched sound from. Again, asthma. If anybody's had asthma before or you've seen it, you know you get that kind of wheezing sound. Okay, and it can come on from anything, whether it's food, having a panic attack, having something stressful going on, exercise, if they're already having some kind of infection. Multiple different things can bring that on. Hay fever will end up looking like a cold. Okay, most time it's just caused from allergens, whether it's obviously pollen, dust, pets. So if they're looking like they have a cold, go ahead and ask them, well, are you allergic to anything? Do you have any allergies that you know of? Or have you been around anything that you're not normally around? So an anaphylactic reaction, okay, so that the problem with that is if it's severe enough, it can cause severe swelling. Okay, if we don't get it treated quickly, it could close the airway up entirely. Epi is going to be our drug of choice. So when we're swelling up, that's all the vessels are expanding out, right? So epinephrine is going to constrict all that back. Again, we're going to give these folks oxygen, oxygen, oxygen. Pneumothorax we talked about a little bit in trauma. It's just that air in this pleural space. Like it says right there, like we just talked about, most often happens in trauma. It can happen spontaneously. It's a little more uncommon, but it does happen. You notice it says right there that vacuum-like pressure that we get, because we're built on a negative pressure system, goes out the window. So there's a nice little picture for you. If they got weak lungs, if they've had recent infections, again, they're going to present with difficulty breathing. They're going to present with possible cyanosis, bluing of the lips, low O2 sat. Depending on which side it is, you may not be able to hear breath sounds at all. So be prepared for that. If you're sitting there listening and you've listened for 10 seconds and still don't hear anything, it might be a good idea to start thinking about, oh, they may have had a pneumo. Your pleural effusions, you got your fluid outside the lung. Again, it's going to kind of press in. It's going to press in on those lungs. Once we press in on the lungs, it reduces the amount of air we can get in there. It reduces that gas exchange. And again, we have difficulty breathing. Multiple different things cause it. There's a few up there: cancer, heart failure, infection. Most of the time, patients will feel better if they're sitting upright, because it'll kind of pull a little bit of that down. They may get a little bit of extra space. Airway obstructions. There could be something in there. If they're choking on something, obviously if they've got something in there and we can see it, we need to move it. If not, we need to try and attempt to ventilate as best as we can. Don't ever do a blind finger sweep. Don't reach your fingers in there trying to touch their trachea. Okay, if you can't see it, don't go for it. A pulmonary embolism, or a PE. It's a blood clot that circulates through your bloodstream. It can either cut it off completely, or it can cut off blood flow a little bit. If it's large enough, it will kill them. Okay, a lot of times with a PE, one of the presentations is they will look purple from about the chest up. And when we say purple, I mean it's very purple. You'll look at it and you'll notice. You'll be like, oh, okay, that's a PE. With those folks, rapid transport to the hospital. Hyperventilation. I'm sure we've all done this at some point or another. Some of us, when we're working out, probably hyperventilate a lot. It could also be an indicator of some kind of life-threatening illness, traumatic head injuries, infections, overdoses, all kinds of things. At the same time, we could be breathing fast because we have a buildup of acid in our body. Okay. So just be aware that there's different things that can cause this kind of problem. Things we may not be able to find out about immediately, but it's good to have that information. And if we're hyperventilating too much, we can have that excess base in the body fluids that causes alkalosis, screws with your acid-base balance. It's a little bit more in depth, but our body sits at a pH of between 7.35 and 7.45. If we're like 0.10 off of that, it's extremely dangerous. A little bit more in depth, but it's always good information to know. Same time, hyperventilation could cause symptoms of a panic attack. They could get anxiety from breathing this fast. They're going to get dizzy. They don't have near as much oxygen going through their bloodstream. Numbness and tingling and spasms in the hands and feet. They might get that T-Rex hands. Okay, that's where they've been breathing fast for so long. The body says that it needs that oxygen everywhere else, and it's going to shunt it off from those extremities. So if you see somebody looking like a T-Rex and they're not trying to be funny about it,
It's crazy because that's actually happened to me, and it's the worst feeling.
You watch Jurassic Park once doesn't mean you're
No, I was sitting in a wheelchair, and it started happening, and the guy asked me to get my ID or something. I couldn't move my hands. It was terrifying. I think that sent me to a different type of shock. It was terrible. It's real. T-Rex hands are real.
It is.
They're terrible.
See it plenty of times. Hardest thing is calming somebody down with that. Most times.
Yeah. I was already panicking before that happened, and then I couldn't even grab anything. And I was like, shit, this is the end. Oh, wait.
So environmental industrial exposures, we talked about this before. Depending on what it is, a lot of times you'll see this at like industrial sites. Tyler Pipe is one. Just be aware of what you're dealing with. Carbon monoxide, I know you guys have dealt with before. You know plenty enough about it. We don't really need to necessarily go over it. Other than that, it's far more prone to binding to our hemoglobin than oxygen is. So even if they do have that pulse ox that says 98%, it's probably not 98% of oxygen. Those people need oxygen 100% as soon as you can. Same time, with any of this stuff, don't put yourself at risk. Okay? If you're not sure, if they say, hang on, there's a chemical out there, don't go in. Again, that goes back to the scene size up. We've already talked about that. Precautions, PPE. Be mindful, okay? When you ask why 911 is activated, don't be a jerk about it. Don't be like, why'd you call? There's easier ways to ask about it. Hey, what's your problem today? What's going on? What can I help you with? Don't just kind of be a bully about it. Primary assessment, again, we talked about this before. Get your general impression. Okay, that's looking at the patient, finding out if they're alert, any life threats, asking their chief complaint. Airway breathing, again, we talked about this before. Make sure it's patent, make sure they're breathing okay. If they're not, check the breath sounds, correct the situation. Circulation, pulse, we talked about that as well. Always make sure that they're not bleeding from anywhere. Double check, and then check their skin color, their temperature, and whatever condition their skin's in. Okay, don't ever forget to check and look at their skin. Okay, because they may be looking like they're breathing decent, but you get that good look at their skin and notice that their fingernails are kind of discolored and their lips are turning. You may not catch that otherwise. Again, decide where you're going to take them, whether that's licensed sirens, closest facility, whatever facility you need to. Most of the time with these people that are breathing problems, they need to go fast. History taking, we talked about that before. There's another word salad for you. Paste, progression associated chest pain, sputum, talking tiredness, exercise tolerance. Kind of help you give a better indication of what you're dealing with. Does it get worse when you get up, move around? How many words are they talking between breaths? How long did it take to get to this point? Are you having any chest pain with it? And that sputum, depending on what color it is, could indicate, what problems they might have. If they're having CHF, they might have that pink colored sputum. Okay, call them those pink puffers. That's where the blood's backflowing into the lungs, and now they're spitting it up. So if you ever see that, start thinking pulmonary edema, CHF. Secondary assessment, again, look for signs of COPD versus congestive heart failure, that wet versus dry. Reassess. Same thing as always, if you do some kind of intervention, reassess it, okay? Emergency medical care, that's what we're doing, okay? That's our job. So we're giving them oxygen, keeping an eye on their breathing. If we need to correct that, we can. They may have inhalers, especially if they have asthma, okay? If they have nebulizers, make sure that we know about that. If you need to, you talk to your medical control, make sure that the medication you're fixing to give is called for. Okay, don't just give anything just because you think that's what they need. Make sure you have some kind of orders for it. Like I says, a lot of these respiratory problems, we're trying to relax those muscles around the air passages. That way everything stops swelling. Okay. So upper lower airway infection. Okay, we're going to give that humidified oxygen. Don't try to suction. Okay, again, if it's swelling up, we don't want to fight with it. Keep them comfortable. Don't make them any more mad than they are. Don't cause any additional swelling. And then just get them to the hospital fairly quick, because they're probably going to need some kind of treatment for it that we don't have. Pulmonary edema. Again, that's where we said fluids in the lungs, 100% oxygen. Suction if you need to with these folks, okay? If it's starting to come up, if they sound like they're drowning in their throat, give them some suction, okay? If we need to, we can give them that CPAP and give them that positive pressure. Try and force some of that fluid out of their lungs. And then again, just like the other one, we're going to transport these guys fairly quick. COPD, just like asthma, they may have an inhaler. Okay, we're going to assist them with it. Okay, side effects for overuse, they've got an increased heart rate, they're real jittery. Those are a couple side effects to look for. And just like everything else, keep them comfortable and transport them fairly quick. Respiratory conditions usually can and will worsen. All right, so asthma, your anaphylaxis, your hay fever, all this stuff is where it's swelling up fairly quickly. If it's not too bad, you can probably give them their inhaler, see if it works. Hay fever, you may not necessarily need to do anything for. Again, like we said, those are cold symptoms. Most time that's okay. That anaphylaxis is when we have to give epi. Whether we give that, it's going to be an injection in the thigh. Spontaneous pneumos, not much we can do about those besides giving them extra oxygen, getting them to the hospital. Same thing with pleural effusions. They have to remove that fluid at the hospital. We can't do that, nor do I want to. Give them oxygen, get them to the hospital. Airway obstruction. If it's a partial, if they can still breathe, if they can still talk, keep them calm, give them oxygen, take them to the hospital. If it's a complete one, if it's caused them to stop breathing, they're not making any sounds, they're turning blue, attempt to get that obstruction out, whether that's the Heimlich maneuver, whether you're able to visualize and see it and pull it out, do what you need to and give them oxygen. And obviously take them to the hospital as fast as safely possible. PEs, keep them comfortable, give them a bunch of oxygen, okay? Because odds are it's fixing to move. We don't want it to kill them, but we want to give them as much oxygen as possible. Again, hemoptysis, coughing up that blood. If it's present, get it out. Go ahead and suction them. Okay, we want to make sure the airway's clear in case we need to take control of it. Hyperventilation. Okay. Unlike most of us as kids when we're supposed to breathe in a paper bag, we don't want to do that. Okay, we want to give them oxygen. Try and calm them down. Be surprised how many times putting a non-rebreather bag on them and talking to them calms some of these folks down. Your exposures, just make sure to take precautions, make sure they're decontaminated, that they're not going to contaminate you, and then treat however the presentation is, whether that needs suction, whether it needs oxygen, whether you have to bag the patient. Treat them however you need to, based on whatever signs and symptoms they have. And then foreign bodies, obviously, again, like before, we're going to try and clear that airway, give them oxygen. All right, so these are a little bit more specialized issues. They have a tracheostomy, they've got that trach right there. If there's any kind of problem with it, try and keep them comfortable. If you can, suction. A lot of times these folks, whether it's them or their parents or whoever is their caregiver, will know how to suction that thing. Ask them. Okay, they're usually better at this stuff than we are. That's okay. They should be experts at this. But again, give them oxygen. Asthma, blow by oxygen, use inhalers, keep them calm, try not to make things worse. Cystic fibrosis, not much we're going to do besides suction and oxygenation, wherever we can. That's a genetic disorder. Most of the time, they'll know they have it. They will tell you. You know, I've got fibrosis. I have this much percentage of my lungs. All right. Let's do a little bit of review. It's a process in which oxygen and carbon dioxide are exchanged in the lungs. It's called what?
A.
A.
B.
A.
A.
Yeah. Respirations. So that's just the definition of changing gases. All right. Which of the following respiratory diseases causes obstruction in the lower airway?
B.
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 Why do you have to rush?
Yeah. So remember, asthma is going to have that wheezing sound. Wheezing comes from the lower airway. Okay, because that bronchioles are constricting. You'll definitely hear it when you put a stethoscope on them. All right. So which following disease is potentially drug resistant and is thought to be transmitted by coughing?
A.
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 A. Oh.
No, you guys are good. Again, that's why we wear those N95s. All the following are causes of acute dyspnea except what?
C.
B.
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 Remember, emphysema and COPD go hand in hand. It's a form of it. Like I was saying, ask them. They may not know that they've had COPD for years, but by golly, they know they've got emphysema from. Trying to find out where my partner is. All right. So bronchospasm is most often associated with what?
A.
B.
B.
Five.
B. 6.
A.
Whatever that is. B.
Oh wow, I didn't notice that. 5, 6, 7, 8. Wow. Hey, look, see,
A.
even the big people who make the books can make a mistake every once in a while. So it's going to be asthma. So again, we get that wheezing, tightens up those bronchioles. All right, sudden onset of difficulty breathing, sharp chest pain, cyanosis, persists despite supplemental oxygen. Is most associated with what?
C.
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 B.
Yeah. Again, like we said, that kind of sharp chest pain, they've got a clot in there. Okay, they may just have cyanosis. Like I said before, they may be purple. We don't know. We just need to be prepared for it. Very dangerous. All right. Albuterol. Interesting one. Beta 2 agonist. Generic name for what?
D.
D.
Ball damage.
Sounds like some people take this medication.
D.
It's going to be D. It's Ventolin.
Hey,
I may or may not have had to refill my inhaler here briefly.
Good thing to remember is if it's a beta 2, we've got
You want to go outside?
beta 2s affect the lungs.
No, ma'am.
Right. So bacterial infection results only the that covers the larynx. Swelling is called
D.
C.
D.
B.
so really it's
Infection or something.
C. It's going to be C. So that the epiglottis covers the larynx. So that epiglottis is what's swelling up. So they'll have that real quick fever that came on all of a sudden, that stridor, that high-pitched sound when they breathe, drooling, and they may be hypoxic. Again, with these kids, don't make them mad. 70-year-old recently had a heart attack. Now he's complaining of severe difficulty breathing, especially when lying flat. He's coughing up pink, frothy secretions. This patient is most likely experiencing what?
D.
Who all's on my
D.
team?
B.
Are y'all paying attention during class? We're talking about those pink puffers. You're going to be having that severe heart failure. Okay. Remember, the left side of the heart's the one that's taking the blood to the rest of the body. Okay. Once it has that problem and it's starting to fail, we backflow into the lungs. That's where they start getting that fluid in the lungs, and eventually they'll be coughing it up. So just remember, when you start seeing that pink froth for a pink puffer, that you've probably got left side heart failure. All right. So which of these guys is breathing adequately?
B.
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 A.
B.
Yeah. So anything for an adult that's considered normal is 12 to 20. They're getting good chest rise. Obviously, if they're alert, they're not having obvious trouble breathing. They're looking like they're pink, warm, dry, otherwise a normal person. Anything else can be considered a problem. All right. Man, we're trucking along. All right. So we've got cardiovascular emergencies. There we go. Number one killer since 1900, setting a record. 1 in every 3 deaths has something to do with the cardiovascular system. Good thing what we can do, a lot of the stuff we are doing, obviously encourage healthy lifestyles. Don't eat pizza all the time. Don't eat wings all the time. Getting access to medical care, early access, making sure they know to call 911 if they need it. Training people for CPR, hands-only CPR has been phenomenal. Has helped out quite a few different people. And like I said, is the increasing technology, using, like we use Pulsera to notify for strokes and stuff, or when it comes to dispatch, text to 911, that stuff's becoming more and more predominant. So the more opportunities we have for folks to get help, the better. Public access to AEDs, another good thing. I encourage it all over the place. Something that we're going to learn is recognizing the need for ALS services. Okay, if it's something we cannot take care of, we need to get them to a higher level of care. And then cardiac specialty centers, cath labs. That way they can get those clots taken care of, those blockages removed. So anatomy and physiology, again, the heart is super important, right? Pumps blood, takes the oxygen-rich blood from the lungs, takes it to the rest of the body, takes everything else and pumps it back into the lungs to get reoxygenated. Okay, we've got 2 different sides. We've got a left and a right. Each one's got a top part, which is the atrium. And we've got the lower part, which is the ventricle. So the ventricle is pumping the blood out. Okay. It's driving me nuts. So there's a little picture. It's got quite a bit of words to it. Just make sure you kind of know what the anatomy is of the heart. So the atria is going to receive your incoming blood. Ventricles, like I said, pump it out. One-way valves keep that blood from flowing in backwards. Okay, that's where when we end up having heart failure, those are the valves that are failing. Okay, they're letting that stuff flow backwards. And then the body's main artery, which is the aorta, is going to receive that blood coming out of the left ventricle. Okay, so that's where it's going to the rest of the body. A couple more pictures for you, kind of show you how blood flow works. So the only difference is that the pulmonary artery takes the blood back to the lung. So that one actually has the oxygen depleted blood in it. And then the pulmonary vein has the oxygen rich. So while everything else, the arteries carry the oxygen, when you're talking about the pulmonary artery, that's the only one that's different. So the electrical system controls the heart. You got a starting signal. It starts at your SA node, your sinoatrial node. Once that pulse goes off, it signals the rest of the heart to contract. Okay, think of it like a guy shooting the gun off to start the race. Okay, once that gun goes off, it's time to go. Heart pumps. At the same time, if something's wrong with that node, if it's defective, damaged, there are other cells in our body, in our heart, that can create that. You have your junctional nodes, which create a junctional beat, and then you have your ventricular escape beats, which comes farther down in the ventricles. So there's a picture of the electrical conduction in the heart. Like I said, that SA node, that's where it starts off. Sends that electrical impulse to tell the heart to contract. The little blue space is your AV node, that's the backup. Okay, so if it doesn't get that signal from the SA node, that's where it's going to start. And then down further, those Purkinje fibers, the bundle branches, that's where you're going to have that other contraction. That's kind of the last resort of the electrical system. Good thing about the heart, it's autonomic. Okay, it works on its own. It does not require active voluntary thought to beat. It'd be kind of rough if we had to sit there and think, tell our heart to beat 60 times every minute. That'd be rough. Okay, but it's got two different parts. We got that sympathetic nervous system and the parasympathetic. So you got your fight or flight response, or your, as they used to call it, the feed and breathe response. That myocardium, the heart muscle's got to have a continuous supply of oxygen. Okay, if that heart doesn't get the oxygen and nutrients it needs, everything else is going to shut down. So when we have that increased oxygen demand, we have those vessels widen. Okay, those coronary arteries widen up. That's why nitro works so well. And your stroke volume is how much blood is being ejected out of that contraction of the heart. And coronary arteries, like we just talked about, arteries supply blood to the body. Coronary means heart, so coronary arteries obviously take oxygen-rich blood and give it to the heart muscle. Start at that first part of the aorta. You've got the right coronary artery and your left coronary. There's a picture of what those look like. Again, they supply the blood to all the body, okay, all different parts. So you've got multiple different arteries. You got your man, it's time to quit. Right and left carotid, your right and left subclavian, brachials, your radial, ulnar, your right and left iliac or in your hips, your femoral arteries, then you have your tibials and your perineals. Okay, I guess it doesn't have a picture of them, but all of those combined allow for oxygenation to the entire body. We talked about capillaries already. We know they're small. Same thing with arterioles. They're very small, okay? Allows for transmission of nutrients, oxygen. Venules are the smallest branches of the veins. Again, veins return oxygen back to the heart to be, return blood back to the heart to be reoxygenated. Vena cava is going to do that. You have your superior vena cava, which means above, and then your inferior vena cava is the lower. So what does blood consist of? Well, a couple different things, right? We've got a red blood cells that has the hemoglobin, carries the oxygen. White blood cells obviously are for fighting off infections. Whenever that increases, if we're looking at lab values, they have an increased white count, okay, well, they're sick with something. Platelets are how we clot. Think of plates stacking together. A lot of times when we give aspirin, we're trying to reduce that portion of it. It's a platelet aggregator. It tries to keep those platelets from binding. And then plasma is just that fluid that all these cells hang around in. So blood pressure. We know how to take a blood pressure, but what exactly is a blood pressure? Well, it's the amount of force of circulating blood against those artery walls. Okay. So our systolic is the maximum pressure generated by that left ventricle, and the diastolic is that pressure against it when it's at rest. So anytime we have a high systolic, that means it's forcing blood out at a harder force, and then a higher diastolic means it's resting. I guess resting harder would be kind of a weird way to describe it, but that's how much pressure is against it while it's resting, while it's not beating. So that pulse we're feeling is whenever we're having that systolic blood pressure going on. So there's a couple different places that you can feel those arteries. Obviously carotid and radial are two we use fairly often. Brachials we use a lot on kids. Femoral, I don't usually use a femoral. Kind of gets awkward with most alert conscious patients. They probably don't want you touching them there. But a lot of times you'll see in cardiac arrest when we get to the hospital, that's where they'll feel for that pulse. And again, your posterior tibial, your dorsalis pedis, those ones are good to check for circulation and how well that person's perfusing. Plus, if they have any kind of traumatic injury, do they even have a pulse down there, is also a good thing to find. Cardiac output is how much volume of blood's coming out of the heart in 1 minute. So that's your heart rate times the volume of blood ejected with each contraction, which was your stroke volume. A little bit more in depth. Perfusion just means it's the constant flow of oxygen-rich blood to the rest of the tissues. What are requirements for good perfusion? Okay, well, they have to be breathing well. They have to have a good heart rate. They have to have oxygenation, realistically no respiratory issues. Mostly what we're doing here, most of us are all healthy, normal. That gives us good perfusion. If that fails, if we start having poor perfusion, eventually our cells die, which leads to organ failure, which leads to death. A little bit of patho for it. Chest pain usually comes from ischemia, which is decreased blood flow. Okay, so when we have that chest pain, it's actually not because something is actually attacking the heart. It's because that oxygen is being blocked and the heart no longer has enough to work. Downside is if we don't get that blood flow restored fairly quickly, the tissue is going to die. Okay, that's why they say time is muscle when we talk about the heart. There's a little picture for you, atherosclerosis. We talked about that way back. Just the buildup, cholesterol, calcium in those arteries. Unfortunately, with the way things have gone, I'm eating a lot of fast food, so there's possibly buildup of cholesterol in my arteries. At the same time, getting older, that tends to happen more often. Okay, so a thromboembolism. Just like we talked about with an embolism, with that pulmonary embolism, thromboembolism is just a blood clot going through the blood vessels. Downside is if it lodges in one of the coronary arteries, we have that infarction, okay, where we have that blockage of the oxygen to the heart. That's where we get our MIs, which are known as heart attacks. Like it says, coronary artery disease is the leading cause of death in the United States. Like I said, we like fast food. We're realistically not very healthy. We have that buildup. Sometimes you can control those risk factors. Like I said, we can start working out, eating healthy, taking better care of ourselves, getting 8 hours of sleep, not stressing out over stuff. Uncontrollable factors could be previous family history. You know, your family may have had history of heart issues. You may be predisposed to having those. Just be prepared that there may be some things that even if we look at this person, well, man, they're extremely healthy. Why are they having a heart attack? It could be some genetic defect. Acute coronary syndrome, ACS, it's caused by that ischemia. Angina pectoris, it's the spasming of the blood vessels in the heart. Man, having a tough time tonight. Downside between those two is angina pectoris and a heart attack can simulate each other. Okay, they may be having that chest pain. It may just be spasming in the heart, or it could be the real deal. Most time with angina pectoris, it's temporary. It will go away. Most time with a MI, it's not going to go away until they die or you get them to the hospital. Signs and symptoms, they got that crushing or squeezing pain. Again, it's not as serious, but this could be a precursor to it getting worse. Because once that oxygen demand goes up, if we don't get enough oxygen to the heart, we can have that tissue death. The difference between stable and unstable is usually you can relieve stable angina. That's where we give that nitro. Those vessels dilate. They get a little bit more oxygen to the heart. They feel better. That chest pain goes away. Same time, treat all angina patients just like you're going to treat somebody having a true heart attack. Oxygen, nitro, rapid transport to the hospital. So that chest pain that comes with an actual true AMI, we're actually having cell death. Okay, they're oxygen starved. They're dying. Once these cells die, we can't get them back. That tissue is dead. Okay, these are the folks that get up to the hospital. They need either, like it says, thrombolytics, those clot buster drugs, or they go in and they remove the clot itself. Okay. These are the ones who are going lights and sirens, regardless of how they feel about it. Okay, all these patients are immediate transport. So signs and symptoms of a heart attack does differ a little bit from angina pain. Doesn't always come on from doing something. Okay. Sometimes folks will be like, man, I was outside, started mowing the yard, I just started having this chest pain. Well, they were exerting themselves. May just be that angina. With AMI, this could last 30 minutes, it could last hours if they sit there and wait for it to go away. Nitro may not relieve that pain. Okay. Because remember, they're having that cell death, so that doesn't necessarily go away. Physical findings, again, like we were talking about, signs and symptoms, crushing chest pain, they'll have that increased heart rate, blood pressure is going to go up, their breathing is probably going to go up because they're going to start having pain. They're going to, man, this really hurts. Mental status changes. If it continues to go on, they may become unresponsive. So be aware of all that stuff. So your 3 serious consequences of AMI, obviously death is probably the biggest one. Okay, we can die from it. Pretty much as bad as it gets. Cardiogenic shock, it's where we have something has gone wrong with the heart itself. Low blood pressure results from that. It can be fatal, but we can still treat that. And then eventually these people will have congestive heart failure because the heart has had to work harder this whole time trying to get more oxygen to it. Results in that failure of that left side. Dysrhythmias, by definition, that just means it's an abnormal heart rhythm, whether that's fast, slow, if they're having extra beats, and then if they have ventricular tachycardia. Ventricular tachycardia is definitely bad because that, like we said, we have those 3 different nodes that signal the heart to beat. VTAC is the last one. That's where the ventricles are in control of the heart and they're beating as hard as they can. That's where if you've seen our monitors and you see really, really wide mountains on there, that's what that looks like. Definitely not something we want to see. Defibrillation can restore cardiac rhythms. So we're just going to use the AED if needed. Early defibrillation does save lives. Okay, it does help recorrect those fatal rhythms. Just make sure that you're doing CPR before you get the AED. Okay, just make sure somebody goes and gets it while you're doing CPR. Hook it up, and as soon as it's hooked up, let it take off and do what it needs to do. At the same time, if it tells you no shock advised, that's going to be because it's asystole. Okay, the heart has no electrical activity whatsoever. Most of the time, that's because it's gone a long time without any oxygen. Usually, if we get to this point, if they're flatlined like that, most of them don't come back from it. Cardiogenic shock. Like it says, most of the time it's caused by heart attacks. Heart's weakened, doesn't have enough strength to pump that blood. Okay, once it doesn't have enough strength to pump the blood to the rest of the rest of the body suffers for it. Okay, we start having other problems with other organs because they don't get enough oxygen. Just make sure you know how to recognize shock in its early stages. One of the first ones is an increased heart rate. Okay, eventually they'll have lower blood pressure or increased respirations. CHF, like I said, we kind of talked about this with respiratory problems as well. Happens a little bit after a heart attack, a couple days later. The body's trying to, or the heart's trying to compensate for that loss of tissue. It starts enlarging that left ventricle. Again, this is where it starts backflowing into the lungs, where we get that pink frothy sputum. Just be aware of that. Hypertensive emergency. So we know that hyper means great, and tensive was pressure. So high blood pressure. Anything greater than 180. If they've got a massive headache, that's probably a good idea that they've got high blood pressure. Common symptoms, altered mental status, especially if they're fixing to have a stroke or a pulmonary edema. Again, that heart is pumping extremely hard. There's a possibility that's going to backflow a little bit into the heart or into the lungs. Again, like it says, if it's untreated, it can lead to a stroke. We can throw some of that leftover blood that's clotting up because it's not getting out of the heart. We can't throw it into the rest of the body or into the brain. Or we can have an aortic aneurysm where we force blood so hard that it's broken open the aorta. Take these patients quickly and safely, okay? Don't stress them out anymore. Don't make things worse because that makes blood pressure go up. If they've had their medication, make sure you get that good sample history. Like it says, aneurysms, weakness in that wall, the aorta, it can bust. Okay? That dissecting aneurysm, the inner layers of that aorta separate. It says uncontrolled hypertension. Uncontrolled hypertension means they're not taking any medication for it. You know, they say, "Oh, I don't need to. I'm good." That's what this leads to. As you know, signs and symptoms. Again, they might have extreme chest pain. Blood pressure may tank on you. Increased heart rate. Signs of shock. Again, these people need to go to the hospital fairly quick. See if they can get taken care of in surgery. So there's a nice little table of your dissecting aneurysm versus your AMI. Okay. So if you look at it, notice that the quality of the pain is different. So you get that tightness or pressure with an AMI. If they got an aneurysm, dissecting one, it'll feel tearing. It's a very unique pain. It does not go away either. They will complain about it and fight you on it the entire time. Like I said, some of these folks, if they tell you that they have a tearing sensation between their shoulders, that's not good. Like it says right there, you may notice kind of a difference in blood pressure between arms depending on where that aneurysm is. You also might have a difference, you might have a good carotid or a weak femoral depending on how bad that is. All right. So to beat everybody over the head, hold on a second, let me see if he's seeing size up. We've already talked about this. It's a broken record. With cardiovascular emergencies, we have to make sure we talk to the family, whoever we can get information from. So like it says, if they're unresponsive and we're called out for a heart problem, go ahead and assume that they're not breathing and they don't have a pulse and start CPR. As bad as it sounds, if they're okay, they'll let you know in a minute. Again, airway breathing, make sure that they've got plenty of oxygen. Anything less than 95%, and we're thinking it's heart related, we need to give them a lot of oxygen. Go ahead and put the normal breather on them. Circulation, we know how to check for circulation. We know what good circulation is. We know what poor circulation is. Most of these folks are going to be rapid transport. That being said, try to keep it relatively stress-free. Granted, we're going to be in the back of a box telling them they have a heart attack. It's not stress-free at all, but we don't want to make it worse. If the sirens make them panic or the lights make them panic, okay, we can take them without lights and sirens if it reduces the stress, because that stress increases the workload of the heart, increases the oxygen demand, which makes this worse. So like we said with history taking, make sure you dig deep into this chief complaint. Okay, if they're telling you chest pain, find out why. How long? What's it like? Does anything make it better? Does anything make it worse? Have you ever had this before? Does it feel just like the last time you had a heart attack? Ask those good questions to get a good picture of what is going on with this patient. So our physical exam, there's not much we can really truly look at if it's a heart attack. We know what the signs and symptoms are though. So base it off your circulation, your respirations. If they have a weakened blood pressure, and if they're having increased respirations, okay, they're probably having some kind of shock. These kind of patients, we're going to take vitals all the time, probably every 5 minutes or less. Like it says, even if we're doing a great job, sometimes they will go into cardiac arrest. Okay, they could throw that clot. They could just, their heart could say, fine, I don't have enough oxygen, I quit. Just be prepared that if that happens, go ahead and start CPR and get an AED. Double check your interventions, rapid transport. Again, with these folks, especially important to do good documentation and good communication. We need to notify the hospitals very early about this patient. Let them know that they're having this chest pain. That way, if they can activate their cardiac teams, their cath lab, have everything ready so that when we get there, it's a very smooth process to get them up into the cath lab and get them taken care of. Position comfort, if they feel better on their left side, keep them on the left side. If they feel better on the right side, let them lay on the right side. Whatever makes them comfortable. Give them oxygen. This will be based on whatever protocols you're using or have for your whatever service you end up working for, but give them that low dose aspirin, and if they have nitro, help them take it. So aspirin, we know, like we said, it kind of reduces that ability for platelets to clot together. That's the reason why we're giving it. We already know that they're having some kind of clot in there blocking the oxygen. We don't want to make it worse. So we're going to try and give them the aspirin to help break it down. Nitro we talked about beforehand in pharmacology. We know it comes in a tablet that goes underneath the tongue, and we know it comes in a spray. Dilates the vessels. Side effect, we know one side effect is they could possibly have a headache. And then contraindications, we talked about that a little bit. We know if they're taking any sexual enhancement drugs, that's a good indicator not to give them this medication. If their blood pressure is lower than 90 or 100 systolic, depending on your protocols, that's another contraindication to giving it. Like it says, we want to make sure it's not expired. If it's expired, it probably will not work, or it will not work as well. At the same time, make sure that the patient's name that's on the vial is the same name as the patient you're fixing to give this medication to. And then wear your gloves. Nitro tabs have a tendency to break apart very easily. You could possibly absorb some of it through the skin. You don't want that. We don't want to expose ourselves to anything unnecessary. All right, so cardiac monitoring, it's always a good thing to go over. It's where we're going to monitor the heart's electrical system. The electrodes have to be placed in specific spots consistently. Okay. If we follow this stuff, it will reduce what's called artifact. Artifact is where we get extra visual disturbances in those views of the heart. So looking at that, you may have to shave these people. if anybody ever has to put an EKG on me, I'm sorry. You can have fun with that. But shave them. Just explain to them, I'm sorry I have to do this. But if you can, you can rub the site with an alcohol swab before application, kind of get any contaminants, anything extra that's there that may reduce that connection off. Always make sure the electrodes are attached to the cables first. That's just, for one, it's a courtesy. We don't want to just plug the electrodes onto this person and try and push these cables onto them. They're already having chest pain. We don't want to make it worse by pressing down on them. And again, make sure they're in the right spot. Most electrodes, especially with our trucks and with our cardiac monitors, will sit there and say, LL for left leg or RL for right leg. So there's your little picture right there. Another one to think of is smoke over fire. So you've got your graphs down there, the green, lights on fire, which is red still on the bottom, and then your white and black are on top. On the other side of that picture, that's for your 12 lead, and that gives you a full picture of the heart. Again, V1, V2, 3, 4, 5, and 6 kind of all go in a row around that part of the chest. When you're doing this, depending on who it is, you may have to lift tissue up. Be mindful of this, be respectful. Use the back of your hand like this. Don't sit there and try to cup it and lift it like that. That's going to get you in trouble. So always be respectful, okay? All right. Once the electrodes are placed, the monitor is going to get turned on. Most time we'll want to print a sample strip. Make sure that it looks good, that there's no artifact. That way, if we need to fix something, we can fix it now instead of realizing it later. So, heart surgeries and cardiac assistive devices. So, open heart surgery is never fun. It's never good for a patient to have it. Definitely means that something has gone wrong with their heart. Coronary bypass graft, what they're going to do is they're going to take a blood vessel from the chest or the leg and sew it onto the aorta. Or take it from the aorta and put it onto the heart. Kind of splice it over there, past that obstruction. That way they can get blood flow back to that tissue. Percutaneous transluminal coronary angioplasty. Big fancy word. They're putting a stent in there. They're going to put a balloon in and inflate it inside the artery and make it wider. That way that blockage is not near as bad. Depending on what type of surgery, they may or may not have that big old zipper that we talk about. It just depends. Always ask them if they have any kind of chest pain. Have you had any surgeries before? Have you had open heart surgery? Have you had any heart surgeries in general? Most times they'll tell you, yeah, well, I had a bypass done, or I had a stent placed. Most of these people will know what has happened to them. Again, when these people have chest pain, we're going to treat it the same, regardless if they have the surgery or not. Just be aware that some people will have those pacemakers as well. Whenever the heart, like we said, whenever those nodes start malfunctioning, cardiologists can go in there, they can place these pacemakers, which force the heart to beat the way it's supposed to. It becomes the signal to send off. So like I said, pacemakers, exactly that, pacemaker. It sets the pace of the heart. Most of the time it's set for 80 with these folks. It's going to send that impulse through those wires straight into the heart muscle. Most of the time you'll be able to see it up in the chest. You'll see a bump if you are doing compressions and fixing to put pads on them, do not put the pads right over top of the pacemaker. Make sure you put it to the side of it or above it. Good thing is these things are reliable as all get out. Most time people will outlast their pacemaker. The battery won't run out. These things are so good. All they got to do is get the battery changed. When they do fail or they do malfunction, people will have all kinds of signs, symptoms. They may start to pass out. They may get dizzy. They may get weak because now that pacemaker is gone, the heart's having to pick up the slack again. So that final, either the junctional node or that ventricular beat is going to happen. So they may have that 35, 40 heart rate. Make sure we take these patients to the hospital fairly quick. Not a whole lot to do with that. We can pace them, but they're going to need to get that device fixed or replaced. So just like pacemakers, there are those automatic defibrillators that you can implant. Hang on one second, he's finally here. So these are the same thing as how pacemakers look, but these will defibrillate the patient. Most time, if somebody's already had a cardiac arrest and survived it, they're going to get this put in. It keeps a constant eye on that heart rhythm. If it notices that it needs a shock, it's going to go off. Again, patients with these, we're going to treat the same way we treat any other AMI patient. The good thing is, if you're got your hands on them and the thing fires off, it's not going to shock you. Okay, it's designed just for that patient. Oh, I hear that country boy out there. All right, y'all go ahead and take a few minute break so I can show them how to do this, and then we'll continue in just a second, okay? All right, so we're talking about external defibrillators now. Sometimes they come in a vest, okay? It's attached to a monitor. It's using high energy shocks. These ones you don't want to touch. Just like when we're doing with the AED, don't touch these folks if it's going to shock them. That being said, the vest needs to be in place while CPR is going on, unless you can't do proper compressions with it. There we go. Okay. So left ventricular assist devices, LVADs. These are devices that are going to help that left side of the heart, the left ventricle pump. With these, be aware that they may have a pulse or they may not. This person may be talking to you and you feel their carotid or their radial and they may not have any kind of pulse whatsoever. Don't freak out. Just be aware that that's probably why. At the same time, family or the patient themselves are going to be able to tell you way more about the device because whenever they get it, they go through extensive training with it and education. So they will be your best help with what to do with those devices. That way, if something fails, they know what happens, what needs to be done. Cardiac arrest, we all know what cardiac arrest is. It's where all cardiac activity stops. No more pulse, no more heart rate, until somebody decided to start pumping on chest. It was fatal. So there's your automatic external defibrillators, AEDs. I'm sure we've all seen them. We know what they look like. Multiple different kinds. They're easy to use, okay? Fire and forget, turn it on, follow the prompts. That's designed so that just about anybody can use it. Like I said, advantages, like I just said, it's easy to operate. ALS paramedics, we don't have to be on scene for this. You can give that quick shock, early defibrillation. So although everybody needs to have the cardiac monitor or an AED put on them, not all of them will require some type of shock. Some of them will be indisystole or have a rhythm that does not require it. Just be aware of that. And again, asystole, flatline, no electrical activity whatsoever in the heart. Most often that's due to a prolonged death. They usually stay that way. Pulseless electrical activity, that's where if we're looking at the monitor, we see some kind of rhythm on there that looks like it should have a pulse but does not. Those do not get defibrillated. And like we said, early defibrillation, very few people will survive cardiac arrest outside of a hospital unless they get early compressions and early defibrillation. Like I get taught during the BLS, the CPR class, that chain of survival, recognition, early use of 911, treatment, transport to the hospital. CPR does prolong that effective period for defibrillation because we're providing some semblance of perfusion to the brain, to the heart, to the body. Like it says down there, non-traditional first responders. That means just everybody. You know, if you guys have gone out with us on some of this stuff, we teach schools, we teach, been to a couple ones where we've taught department managers for like Walmart, teach everybody how to use these AEDs because most of them are in public places. The more people that know how to use it, the better. So ALS, post-stress care, if we get them back, obviously we're going to continue to ventilate if they need it. Keep their O2 sats up high, trying to make sure their blood pressure is staying adequate. Blood glucose levels, okay? We need to make sure they have enough sugar in their body. So anytime we have a cardiac arrest, if we can, we also get a blood sugar on them. And then, again, rapid transport to the appropriate hospital. Most of this was actually taught in the CPR class. You know, the AED and CPR kind of go hand in hand. The AED will tell you when to push on the chest. Obviously, don't touch the patient during the analysis. It may interfere with it, and it may not say to shock when it really needs to. And at the same time, if it gets ready to shock, don't touch the patient. So AED maintenance, manufacturer settings are always the best. Whatever they recommend on changing the battery, whatever the manual says, follow. If it fails, make sure to document it and get with that manufacturer. Always something to check at the beginning of your shift. Most often, these manufacturers will have a maintenance list for you. They can give you a checklist, that way you can check it off and make sure it's working properly. Medical direction should approve written protocol for AED use. Well, that's basic BLS CPR. Continuing education with skill competency is generally required. That's why we have CPR taken every 2 years. Okay, that whatever that card is valid for, whenever it's time to renew up, you renew it. That shows you're proficient in using that equipment. Preparation. Whenever we're doing cardiac arrest and we're fixing to defibrillate somebody, make sure that the electricity doesn't hurt anybody else. Okay? If they're in a pool of water, don't defibrillate them. Okay? That water will have a tendency to diffuse that shock. At the same time, if they're touching metal, move them away from it. Okay? Metal's an extremely good conductor. We don't want to send a bunch of electricity through this patient and have it conduct through that metal as well. So, like I said, a lot of this stuff we've gone over before when we had that CPR class. If they have some kind of patch on their chest, take it off, wipe it down with a towel, then put the pad on. If they have an extremely hairy chest, shave it. If you have extra pads and no razors, put the extra pads on them and rip it off. If they're a trauma patient, obviously we want to make sure that they take C-spine precautions. And in a tiered system like ours, call for ALS assistance. Okay. There's your little algorithm right there. Kind of just goes over what we taught in CPR. In chest compressions, follow the AED prompts. That's basically what that goes over. Cardiac arrest during transport. Ideally, it would be nice to stop the vehicle. Then begin CPR, call for ALS support, analyze the rhythm with the AED, deliver the shock if needed. If not, resume CPR, and just continue on. Okay, with us, most of the time we're going to be transporting these patients. We'll have ALS in the truck with us. We're just going to keep on trucking. Okay. If you have the AED available but you don't have ALS, don't wait for them. Okay. That's when you notify them, hey, we have this patient on board. They're in cardiac arrest. We're continuing compressions using AED. Advise when you can meet with us, but don't wait for them. So in a perfect world, this patient has their pulse come back. Their heart starts pumping again. We've saved them. Yay. Okay. Now we're going to kind of keep an eye on them. See if they have spontaneous respirations. If not, breathe for them still. Keep an eye on their blood pressure. It may be a little low initially. Watch it over the next 5 minutes, 10 minutes. If they're waking up, see if they can follow simple commands. If they're doing that, then you've done an incredible job. And again, immediately transport. If you don't have ALS en route, take them and go. You got them back. Let's keep it that way. All right, let's review. All the following are common signs and symptoms of cardiac ischemia, except what?
It's a headache. A.
A.
Yeah.
A.
Cardiac ischemia is related to the heart tissue lacking oxygen. The brain's lacking oxygen, we're probably going to have altered mental status. So when palpating the radial pulse of a 56-year-old man, note that it is 86 beats and irregular. What does this mean?
D.
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 Yeah. Like we said,
D.
this rhythmia is literally an abnormal heart rhythm. So if you feel it and it doesn't feel like that beat's coming exactly the same every single time, it's probably a dysrhythmia. Right. Same 56-year-old dude had an acute myocardial infarction, which the following blood vessels become blocked, lead to this condition.
B.
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 Yeah, the
B.
artery recording.
Only felt 96.
Yeah, so it's B. Remember, arteries deliver oxygen to the tissues, okay? And coronary means heart. All right, so a major controllable risk factors for AMI include what?
C.
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 Go with C.
C.
D.
Go higher. So much higher. Oh my god.
Yeah. We can control, remember it said controllable stuff we have control over. So smoking is a major one. We can quit smoking or not smoke at all. Man, my brain hurts. All right, patient with cardiac arrest secondary to VFib has the greatest chance for survival if the ventricular fibrillation, the heart's sitting there quivering.
C.
A.
C.
Oh, C.
I hope CPR started within 10 minutes. Oh boy. Yeah, it's going to be C. Okay, early defibrillation for these folks. All right, 59-year-old woman presents with chest pressure. She's conscious and alert. Skin's cool, pale, and clammy. The first step in treatment should be what?
D.
B.
D.
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 Think back to your assessments. Remember, we have our scene size up, our general impression, and then our primary
Can
assessment.
I pull out my AR, please?
So we're gonna give them oxygen that goes with that airway and breathing, right? So remember, when we do our primary assessment, we start with, if they're alert, what their general impression looks like, and then airway, breathing, circulation. So we don't need necessarily a blood pressure first. We just need to know if they're breathing well or not. Ooh, well, I probably saw the answer for this one already. But if a patient with an implanted pacemaker is in cardiac arrest, the EMT should what?
D.
D. Place them away from the pacemaker.
Yes, C.
Yeah. Like I said, if we see that bump, we don't want to put it right on top of it. Okay. For one, that shock may end up damaging that pacemaker beyond repair. All right. Main advantages of the AED are what?
A.
D.
I'll tell you for
A.
and then I can-
You'll need B and C. Or
Anytime it shows all of the above, it's probably a good idea that it's all of the above. So it does.
how is AED easier than CPR if it goes hand in hand?
That's a good point, but let's take it like this. If you were to ask any random person on the street, hey, I need you to pump this chest exactly this way in this location, or hey, turn this on and follow the directions, which one are they going to be able to do easier? Probably AED. Right. So once we give this patient a nitro, what do we need to do next?
Say B.
B.
E.
B.
Holy,
B.
workout flag.
Yeah. If we're going to give this patient a medication that could possibly lower their blood pressure too low, we're going to definitely recheck it. Speaking of nitro, it's contraindicated in what patients?
A.
A.
Yeah, A.
Yeah.
A.
And like I said, some protocols differ, but the majority say if it's less than 100, don't give it. Same time, like it says right there, if they've got ED drugs on board, don't give it to them either. Pause this. Let's get going. All right, neurologic emergencies. Like we said, most of these involve the brain. Like stroke. Stroke is still the fifth leading cause of death. but it is the leading cause of adult disability. Unfortunately, it is very common in geriatric patients. Like we talked about with the heart, kind of having to work harder and enlarging. These patients, their hearts have been working hard for so long. They've also had cholesterol buildup, atherosclerosis. They have a bigger tendency to throw clots or have things break off. Different contributing factors, like I said, hypertension's one, history of obesity, smoking, genetic predisposition to it, hyperlipidemia, all kinds of stuff. Good thing is, new treatments are coming around every day. It used to be just if you didn't get them there within 4 hours, they were done deal, couldn't do anything for it. Now, with technology, they're doing interventional radiology. They're able to go in and pull these clots out possibly up to 72 hours after it happens. There's been some really good trials out there, lots of good studies. So seizures, like I said, seizures, basically the brain's kind of short-circuited. Everything kind of goes haywire. The other more common one is just altered mental status in general. Like we know the body's the brain's computer. Some of us run on, Windows 10. Some of us run on Windows 3.1. Some of us run on dial-up. Just be aware everybody's body functions differently, just the same as their brain tends to function differently. It does control the same main parts. We all have our brains control our breathing, speech, body functions, what we do. 3 major parts of it: the brainstem, the cerebellum, and the cerebrum. The cerebrum is the largest part of our brain. That big old thing right there, that is your cerebrum. Your cerebrum's that smaller part near the brainstem. So your brainstem is a lot of your survival functions, your basic functions. The cerebellum portion, that smaller part, controls your muscle body coordination, when you want to move something, how it moves. So the way our body works is we send electrical impulses containing information to those nerves in the other parts of the body. So the brain will send something saying, hey, move your fingers, and your nerves will move those fingers. That's done with the cranial nerves and the spinal nerves. Just a little bit of anatomy and physiology, what you're looking at. You got your cerebellum there, your cerebrum, the brainstem, foramen magnum. It's the hole your spinal cord sits in. You got your spinal cord, and then down there branching off of it are your spinal nerves. So again, like we talked before, during traumas, anything that damages above C7 has the potential of cutting off breathing, and that's because it's so high up in the neck. Right. So, like it says, many different disorders can cause brain dysfunctions, all kinds of things: traumatic head injuries, sepsis, seizures, strokes, chronic overdose, all kinds of things. Like I said, it affects speech. We know when people have strokes, it could slow their speech permanently. They can lose lots of muscle control on one side of the body. At the same time, the brain is very sensitive to different changes in its oxygen levels, its glucose levels, and temperature. Most of the time, if any one of these changes significantly, you're going to see a change in mental status. That's why when your blood sugar drops down real low, people act odd or stop functioning. Same thing with oxygen. They get hypoxic. They won't be able to respond to you anymore. Or if their temperature shoots through the roof, they're pretty much boiling on the inside. Their brain can't handle it. Headaches. Headaches, we all get them. Okay, some of them are called, kids. But headaches, they can be a symptom of another condition, or they can be a problem just on their own. Most of the time, a very, very small percentage of those headaches are caused by a serious medical condition. Okay, most time headaches are just simply that, spasms of the blood vessels. Tension headaches caused by muscle contractions in the head and neck, attributed to stress. I'm sure we've all dealt with these before. This is that squeezing ache. Most of the time, they don't require medical attention. Okay, you pop a few ibuprofen and you're good. Migraines. Original thought was that they are caused by changes in blood vessel size. Okay, whether it's expanding real hard or contracting. These are those ones that are pounding real bad. Some people have to go sit in a dark room with nothing going on to get rid of it. Most of these can cause nausea and vomiting, and they can last for a long time. We've had a couple dispatchers that have massive migraines that have lasted for 2 days. Sinus headaches. If you've ever had sinus issues, you know what these are. You have a buildup of fluid in those sinus cavities, and it causes a lot of pressure in the head. So here's a nice little table of kind of the red flags we need to look for when we're talking about headaches. If it's sudden onset, if it's what they describe as a thunderclap, where it's a massive amount of pain real fast like that, definitely something that needs to get looked at right now. If they've got altered mental status, if they're over the age of 50, if we think they have a high risk for infection, neck stiffness, pain, fevers, changes in vision, or obviously if they have like facial droop or paralysis of one side. Strokes, they're called cerebral vascular accidents, CVAs. Much like heart attacks, it's where that blood flow is stopped to the brain. Again, just like it destroys that muscle tissue in the heart, it's going to destroy brain tissue and result in decreased function. Ischemic strokes, that's the ones where the clots block it. Most of the time, that's the one you're going to encounter. It's either from a clot itself or an embolus, whichever one. Symptoms can be, I just had a little headache, or, I felt kind of tingling in my fingers, to complete paralysis on one side or total unresponsiveness. Like it says right there, atherosclerosis, that buildup of cholesterol plaque in the heart vessels and blood vessels, is usually the number one cause. So there's a nice little picture of it. Once that clot gets there, it blocks off that oxygen flow, it damages all that tissue past it. Once that tissue is damaged, it's not likely to come back. Okay, very, very few times can we get them reperfused. That's where that original 4-hour window came in. So there's your hemorrhagic strokes. This is where you have those we call brain bleeds. A lot of times these are fatal. Depending on the patient, there's increased risk factors. If they have high blood pressure, history of blood thinners, if they've had any traumatic injuries before, all those kind of predispose these patients to having that problem. Berry aneurysms. These are a little different. They happen in healthy young folks. Okay. Ends up, they'll tell you that it's the absolute worst thing they're having. They've never had a headache like this before, but it causes that subarachnoid hemorrhage, which we remember the subarachnoids that layer inside the brain. Okay, you've got your subdural, your subarachnoid, your epidural. This thing's trying to restart again. All right, so TIAs, those transient ischemic attacks. Whenever these stroke-like symptoms go away, this is what the TIA is. They'll originally call, I think I'm having a stroke, and you'll get there and they'll say, it went away. I think I'm okay. Well, you're not. It just dissipated. Most time when people start having TIAs, they're going to keep continuing until they have the big one. Like I said, about a third of those patients are going to end up having a stroke. Don't let these people sit there and say, "Oh no, I'm going to be fine." No, they need to go get checked out at the hospital. Okay, if you're having a TIA, you're that much closer to having a stroke. A little bit of signs and symptoms. We talked about this a little bit. Facial drooping. It can be the complete thing or one side. Sudden weakness, numbness in the face, arms, leg, one side of the body. That's where we do our stroke test. We lift their arms up, and if one of them falls, it's a good indicator. Decreased movement, lack of muscle coordination, loss of balance. They can't walk right. Okay, they're starting to drag that foot because they don't have any function in it anymore. Or they could possibly have blurred vision, loss of vision in a certain eye, or even double vision from an increased blood pressure. Same thing, difficulty swallowing. That goes back to that motor control. Altered mental status, speech disorders, that slurring of the speech. They may be trying to talk to you, and in their head, it sounds like they're saying what they're supposed to be saying, but when it comes out, it's just a bunch of jarbled gunk. And this continues on. There's quite a few different signs and symptoms for this. Okay. Eventually, we get down into the coma and the unresponsiveness. So, left hemisphere strokes. A lot of times, this will cause that difficulty with talking or understanding speech. At the same time, we know the left side of the brain controls the right side of the body. So if they're having right-sided paralysis, it means the left side is possibly being affected. Same thing, if it's in the right hemisphere, it's going to affect the left side of the body. They'll still be able to understand you and talk. They just may be slurred speech. They may not understand that they have that problem. A lot of times you can check them and say, well, hey, whose arm is this? Is this arm working? Oh, no, I don't know. It's not mine. Bleeding in the brain, like we said, one of the increased risk factors for it is hypertension. So just be aware that if they have hypertension and they're complaining of a headache, that may be what's causing it, is a brain bleed. At the same time, it could be a reaction to the bleed itself. Just kind of take a look at their sample history, that medication, if they're taking hypertension medications, it may not be related to the bleed. It may be what caused it. At the same time, if they're not taking any medications and this is something completely new, then that may be a reaction. So there's conditions that may mimic a stroke. Obviously, number one is that hypoglycemia. People act altered all the time with low blood sugar. Again, that's why we harp on taking a blood glucose as often as we can. Postictal state from a seizure. Once patients have that seizure and it's over with, their brain has to reset. It has that cool down time. So during that time, they may be altered, they may be unresponsive, or they may be combative with you. All of those can still mimic a stroke. Or they may have a slight subdural or epidural bleed that's pushing in on the brain. So like we said, seizures, that surgical activity, short circuit in the brain. 2 to 3 million folks in the world have epilepsy, or in the U.S. It's quite a few. Probably all know somebody that has it. So tonic-clonic generalized seizures, okay? Usually involves both sides of the brain. This is that unconsciousness and kind of major twitching of all those muscles. Usually lasts for quite a few minutes. Absence seizures, just based on the word absence, doesn't involve motor activity. Okay, nothing changes. They may just have a moment where they're sitting there and talking to you, and all of a sudden they just kind of stop, stare out, don't respond to you. That may have been a seizure. So partial focal seizures, no change in their consciousness, but they may have that numbness, weakness, dizziness, visual changes, unusual smells, auras. It may cause some twitching of a body part or paralysis. Complex ones, this can be, like it says, lip smacking, eye blinking, kind of random jerking movements. Like it says, a lot of times these folks, they'll tell you, oh, I'm having an aura, or, I get that taste in my mouth, or I hear something. Just be prepared that that may be their precursor to this. Like it says, most seizures last about 3 to 5, and then they have that post-stictal state where they're altered, not responsive. So absent seizures used to be called that petit mal. Okay. Again, they may not know what happened during that point from when this started to when it ended, but it's usually not very long. Status epilepticus, they're very dangerous condition. So that's where this patient's had a seizure and then they go through another seizure and another and another and another, and they don't regain consciousness. They're not alert for possibly 30 minutes or longer. Multiple different causes. Some of them are congenital, they're born with it. Could be structural, something with the brain, metabolic, some kind of balance in the body has been thrown off. Could have had some traumatic injuries before. Febrile seizures, if they have a increased temperature, most of the time that's only affected for children. And then epileptic seizures are usually controlled by medication. Okay, so like if they're taking Depakote or anything like that, be aware that those medications are treating seizures. Always a good thing to know which medications do what for this. So there's a little table, kind of gives you an idea of common causes for which ones. Something good to look at. Again, febrile seizures most often occur with children, very young children. It's a good idea to find out when this thing is happening and whether or not it's different from any of the other ones. Okay. Post-ictal state, like we said, this person's now relaxed. Breathing may be labored at this point. You're going to be confused. If they don't recover within 5 to 10 minutes, start considering other issues. Maybe they're hypoglycemic, maybe they have sepsis, and that's what's causing these seizures. Just don't ever rule anything else out as a cause. Okay, because if they don't come around in 5 to 10 minutes, we need to go hunting. So seizures are often mistaken for syncope. That's because people tend to pass out. Difference between that is those folks usually have some kind of motor activity associated with it. Syncope is just straight passing out. Altered mental status. Okay, most common. All kinds of different causes. Like we said, hypoxia is a good one. Hypoglycemia, intoxication is a very good one. I can definitely say I've had altered mental status from intoxication. So just be aware that, like everything else, multiple different things can cause these conditions. Okay. It says hypoglycemia. Good thing with that is if we can have them follow commands and swallow, we can take care of that. Delirium is actually a symptom, not a disease. Most time it's either brought on by a physical issue or a mental problem. We can treat those with the proper treatments Just depends on what caused it in the first place. Just be aware, especially with excited delirium, they may be difficult to handle. So there's a couple different issues. They may not unrecognized head injury. They may not know originally. It could be that they bonked their head on something and didn't think anything of it. Well, it turns out they caused themselves to have a minor bleed, and now they're altered. Severe intoxication is a very good one. Medication complications. A lot of times medications interact with other ones. Like we said before, it may increase the effects of one, decrease the effects of another. And then infections, like we said, meningitis can be one that affects the brain or the bloodstream itself. Okay. All right, back to this horse to beat. Scene size up does not change. Again, we're looking for what's the problem, how many patients we have, any hazards to ourselves, primary assessment. Any patient with altered mental status obviously should receive oxygen, high flow. At the same time, hyperventilation may have quite a few different consequences. Okay, most of them negative. We may blow off too much. They may slow their breathing down on their own, stop breathing. We may put too much air into the stomach, have them vomit and aspirate. Blood pressure could go up, could cause more pressure going into the brain and cause a brain bleed itself. Multiple different things to consider. Just make sure you're breathing appropriately for whatever patient that is, whatever age range they are. Get a good history, especially with strokes. We need to know when the last time they were normal, not just when did this happen? Oh, well, I woke up like this. Okay, but you were normal yesterday at 6 o'clock and went to bed at 6:30. Okay, large time difference. Secondary assessments, again, a lot of this. The more pressure pushed on that brain, the more of a possibility of the heart rate slowing down. At the same time, blood pressure usually will end up being high. Sometimes you'll see change in those pupils. One side may be larger than the other, may be blown out. Again, like I've been saying, check your blood sugar levels, okay? We want to make sure that they are indeed having a stroke and not that their blood sugar is in the 20s. A couple different stroke assessments there. Like it talks about, the Cincinnati one is the one we use the most often. That's, saying, hey, hold my hands, I'm going to hold them up. I'm going to let go, keep your arms up, smile for me. You can't teach an old dog new tricks. Important with these folks is to reassess them. Same thing like we did with the cardiovascular patients, every 5 minutes for these guys. So there's your Cincinnati stroke scale. Fairly familiar with that. Los Angeles pre-hospital stroke screen, not used very often around here. So the 3-item stroke severity scale. Your GCS, that's a very good one to look at, okay? If you can memorize this and be able to tell somebody's GCS without having to sit there and calculate it up or look at it, I will be impressed. But definitely a good thing to look at, okay? If they're spontaneous, eye-opening, 4, if they're confused, it's a 4, and then they withdraw from the pain that you're giving them, that's another 4. So they've got a 12 out of 15. If you notice, even if they're completely dead, they'll still get a 3. Most of the time, if they're less than 8, there is a severe problem. The mentality used to be less than 8, intubate, because we weren't sure if they'd be able to control their airway. Not necessarily the case anymore, but that was kind of a nice little indicator of how severe it could be. Again, so with these folks, it's not necessarily our job to figure out if they're having a brain bleed or a clot. That's the hospital's job. Our job is to get them there in a timely manner and let them know how long this has been going on. So again, like it says, the last time they were known to be well, last time seen normal. So if it was, if we did this tonight and they were seen normal at 7:30 p.m., let them know that. That gives them that specific time frame of when they were seen normal. Again, folks that have seizures, regardless if they've had a history of it, they do need to go get looked at the hospital. Okay. And when they're having a seizure, obviously we're going to try and protect them from harm. Most of the time, if they're large movements, we're going to do our best to keep them from hurting themselves or anybody else, but keep a good airway open once that postictal state's out. Suction. At the same time, if they've had this massive seizure and now you're worried about, well, could they have had any head injury or neck pain from this, go ahead and get an X collar out and put them in C-spine precautions. Headache wise, again, like we talked about, if they're complaining of a sudden massive thunderclap type headache, it's a big red flag. Again, if they've had a headache with fever, seizures, altered mental status, trauma, another thing that probably indicates an underlying serious condition. Same thing with a migraine. Migraines are fairly awful. Support the ABCs. Rapid transport, like we said, to a stroke center. So not just any place. The good thing in our area is that every UT facility is a stroke capable center. Keep their oxygen up. Same thing like we have with cardiac patients. We want it above 94%. Same thing if it's 94% and you're not having to do anything for them, no harm, no foul. You don't have to really mess with it. Because at the same time, if we give them more oxygen, it could possibly increase demand on the brain and on the heart. So going back to treatments for them at the hospital, that thrombolytic therapy, the clot busters, TPA can be given, or they may go in their interventional radiology and pull the clot out mechanically. Again, that's why we're transporting these stroke centers. That way they can get looked at, find out whether it's a stroke or a ischemic stroke or a hemorrhagic stroke. Again, seizures, we may not be there for the actual seizure show. It may be that they're postictal. Just be prepared for if they are actively seizing, what we need to do with them. Again, keeping them safe, being prepared to manage their airway if they stop breathing, calling for ALS assistance. That way we can give them medications to hopefully stop those seizures. And then be prepared for them to be severely altered. All right, review. So 41-year-old male presents with a slow, irregular breathing, hypertension, and dilated pupils. These most likely indicate dysfunction of what?
So we'll be done by next week.
A.
Don't
Okay. Okay. Yeah.
guessing.
It is A.
Oh.
Remember, it said irregular breathing, dilated pupils, and irregular breathing and hypertension. Remember, life. Okay. Ischemic stroke is caused by what?
D.
D.
So remember, ischemic is blocking the oxygen. Is caused by a clot. Hemorrhagic is that brain bleed. All right, 56-year-old man experienced a sudden severe headache and became unresponsive. He has a history of high blood pressure. This is the cause of what type of condition?
A.
Say it.
A.
Say it.
A.
Yeah.
I didn't have it turned on yet.
Right. So, like we said, that kind of big thunderclap headache. We already know he has a history of high blood pressure. Like we said, that could be a very big cause of having a brain bleed. Transient ischemic attack is characterized by all of the following except which one?
Yeah. Okay. Except.
A big word in
B.
caps.
B.
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 So remember, it's going to resolve within 24 hours. That's where that transient word comes from. If it goes on more than 24 hours, it's not just a transient. Patient with suspected stroke presents with slurred speech, difficult for you to understand. That's referred to.
B.
D. B.
B. C.
Dysarthria. Dysphagia is that difficulty speaking.
Oh, yeah.
Aphasia is the inability to speak. Okay? Dysphagia is a lot of the same kind of sounding words. So just be cautious if you see that on a test anywhere, regardless if it's here or national registry. Make sure you know which one. Characterized by severe twitching, lasts for several minutes or longer.
D.
D.
Generalized ED. Okay, that's severe twitching of all the body's muscles. That's why I call it generalized.
Hey, you guys want to see it?
Well, we transporting stroke to the hospital is because
B.
B.
B. B.
B.
yeah, it's B. Because, if we get folks there in a timely manner, they can reverse this thing. Ben was asking about calls for flying strokes. We don't initially have to call too far. It's going to take more on. if you ask me,
Hey y'all, in between answering, can we mute so we can hear?
yeah, let me see if I can mute everybody. There it is. There it is. So, while there's no protocol per se for whether we need to fly these folks out, personal preference, I can pretty much get anywhere within the time it's going to take that helicopter to wind up, get over there, set down, put them on their stretcher, and then get back up in the air. So just take that into consideration. Most of the time, we can get there faster than they can. It's not to say don't think about them, but realistically, case in point, equipment has a helicopter sitting out there. Can we meet them there from farther north and have them take them to Tyler? Sure, we could, but they're sitting at a hospital. We can go into the hospital, get that patient looked at, have them CT'd, and then they can take them via helicopter. So, all right, let's see if we can finish this. All right. Which following are components of the Cincinnati Pre-Hospital Stroke Scale?
C.
C.
D.
C. Or D. I don't know.
So which one is it? You're giving me like 4 different answers. It's gonna be C. Okay. So we're looking for that facial symmetry, whether they have facial droop, speech. You can't teach an old dog new tricks, and then that arm drift. All right. Here we go. Your patient opens his eyes when you say his name, makes incomprehensible sounds, and withdraws when you pinch his earlobe. What's his GCS?
B.
A.
A.
Yeah, so it's going to be A. Okay.
Boom.
So anybody that opens their eyes to verbal stimuli is going to be a 3. When they make incomprehensible sounds, it's a 2. And like we said earlier when I was talking about it, withdrawing from pain is a 4. Last one. The patient complains of a severe migraine. How should she be transported?
C.
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 B.
A.
Yeah. It's going to be C. We're not going to do lights and sirens because, for one, brightly lit ambulance, she's going to be hurting. Loud sounds could potentially make it worse. And then we obviously want to take him to the hospital. So just try and make it as quiet and dim the lights if you can. That way you don't make things worse. All right. Look,